pretty much what is going on in the United States and also a little bit in Canada with trying to make psychedelic drugs into prescription medicines. And we have a series of studies underway or about to be underway. And so I'll introduce everybody initially just so you get a sense of the range of what we're going to be talking about. And then we'll have short presentations and we'll hopefully have time for questions afterwards. And then also tomorrow from 4 o'clock to 7 o'clock, if it lasts that long, there's a supplemental program where we'll be presenting in more detail. So tonight is everybody sort of giving a little bit of overviews, and then we'd welcome much longer discussions and longer presentations to get into real details about the different projects. And I think that'll be out in the chairs somewhere, I think near the maps table or something, but we're in the supplemental program from 4 to 7 tomorrow. I'd like to welcome you all here. We'll have Charlie Grob. Dr. Charles Grob is involved with a Hefter research-funded project that's looking at psilocybin in the treatment of anxiety associated with advanced stage cancer. Dr. Michael Mithoefer is working in Charleston. We've been rejected by the institutions in the area. They weren't ready to be affiliated, so he's doing an unaffiliated study, which in a way offers a lot of advantages. He has sort of a psychedelic bed and breakfast that's really a tremendous treatment facility, and it's the MDMA posttraumatic stress disorder study. And that actually is the core of our drug development effort at this point, and we've been able to build on that for moving into Israel, moving into Switzerland, and well, Michael will tell you more about that. Dr. John Halpern is working at Harvard Medical School on a series of projects looking at the risks of MDMA for neurocognitive studies, but also trying to begin the work with MDMA for advanced stage cancer, again with anxiety associated with people with 12 months or less to live. And what we're hoping is that that study will receive the DEA approval. I was kind of wanting to check email. I mean, we're expecting it soon, but with the DEA, you know that their main strategy is delay. And they've indicated to us in several emails that they will approve the study. It's just a matter of time. We're not sure exactly how long, but John will be working to really try to develop a whole new avenue for MDMA for working with advanced stage cancer. Valerie Mojeiko works for MAPS as our clinical research associate. She's the person that really helps get the quality to the pharmaceutical company level of the studies that we need to do, so that when the governments want to audit it, when you want to do scientific research and publish it in a journal, that's one level of data gathering and rigor, which is really important. But when you want to try to make policy change, when you want to make drugs into medicines, there's a whole other layer of oversight that the studies are really put to just to make sure that the data is reliable. So Valerie's in charge of doing that on all of our different projects, and she's also been working on a project with Ibogaine in the treatment of substance abuse that's going to be starting, we hope, fairly soon in Vancouver. So in a sense, we have a portfolio of projects. It's really important to have something to do with substance abuse directly, so for that we're looking at Ibogaine. And then Andrew Sewell is a board-certified psychiatrist and neurologist, and one of the only few hundred or so in America that have those dual certifications. He's also working as part of John's team at Harvard Medical School, and he's working to try to develop the LSD psilocybin cluster headache study. And they're also, by the way, they're using Hawaiian wood rose seeds, they're using psilocybin mushrooms, and so things that are more accessible. But Andrew's working to develop that project. So with that as the overview, there's no other psychedelic psychotherapy project that we know of in the United States at this time, or really anywhere else in the world. So this is the effort to move it through. And we'll start with John Halpern to explain about his projects. Welcome, John.
Thank you very much. I'm just going to give some overview, no slides. We hope to just move things very quickly today, so really just 10 quick minutes. Rick Doblin in his last lecture mentioned he's trying to bring psychedelics back to Harvard, but I've been working at this since 1994 and full-time in academic research since I finished my residency in 1998. So it's starting to happen, especially now when other brilliant, bright people want to work with you, like Dr. Sewell, who will talk later. I'm interested in how hallucinogens affect people. So I'm a clinical psychiatrist, and I've completed a research fellowship in drug and alcohol abuse research, a clinical research program at the Alcohol and Drug Abuse Research Center at McLean Hospital, Harvard Medical School. And working with people like Dr. Harrison Pope of the Biological Psychiatry Lab, we've been able to look at long-term peyote users, members of the Native American Church, for example. In the first study that had seed money from, in this case, Hefter Research, HRI, and then a K award from the National Institute on Drug Abuse. So HRI has contributed to a project that wound up yielding collaboration with NIDA, and Rick's assistance with us has done much the same, which I'll quickly mention. I spent 5, 6, 7 years going out to Navajo Nation primarily, interviewed over 1,000 Navajo, and had a rater, a psychologist, do neuropsychological testing on 3 different groups of Native Americans, not knowing which is a member of either of them. One of them were lifelong members of the Native American Church, had, seems better, lifelong members of the Native American Church, and had participated in at least 100 peyote meetings. So they were born and raised taking a substance that contains mescaline, a Schedule I drug in the United States, but not for them. It's literally the non-drug sacramental use of this. Second group were alcoholics, now sober, no peyote. Third group, teetotalers, people who've never used alcohol, peyote, or anything. And the neuropsychological testing of these people showed that they were healthy, like the controls on, no matter how I cut the data and take a look at by race, or, well, in this case, they're all Navajo, but by socioeconomic status, by education, by premorbid levels. And the paper was published in November in Biological Psychiatry, and got some press attention because now Native Americans are able to point to some data, finally, showing that what they already know to be true is that it doesn't harm them. And they feel tremendous relief that the government won't just be promising to keep protecting this for them because of treaty obligation, but because there's now science on their side too. And I'll mention where we hope to take that study. That was with data of a set of a couple hundred Navajo. The Navajo who did eat peyote, by the way, were more well-adjusted and had less depression and anxiety than the other 2 groups. And that held true by extent of peyote participation. So it correlated fairly well with extent of peyote use. We have another study where Rick mentioned as well, $15,000 of MAPS funding yielded a $1.8 million R01 grant from NIDA for us, looking at the neurocognitive functioning of pure ecstasy users. Same sort of deal with the psychologist not aware of who comes from which group. In this case, they're all from the rave community. They're either straight edgers who don't use any drugs at all, or they have only used ecstasy. And initial data has been published, and this goes to safety. Our pilot data, 40 individuals, and people who have moderate to heavy use of ecstasy don't have verbal memory deficits, which is really a surprise. And for those that have published with their polydrug abusing individuals that said that there were these problems. So that's why I hope to test a few hundred of these people over the next few years, and let's see how variables like mental illness, other premorbid variables as education, as I mentioned, things like that, how that might impact. Maybe some people are very impulsive who take ecstasy 100 times, or quite different than a greater population who take it only a few times. And that might help understand then how in this case, MDMA, ecstasy, is dangerous for some, or in some ways, since there's no warning label on an ecstasy tablet. That study did offer reassurance to my lab and the administration enough that offering 1 dose of MDMA to somebody, for example, who's dying, I don't feel like we're posing any special risk to them that we couldn't inform them of it and see if it actually offers some help. So granted, there's been delays for the last year at the final step. We have an IND license for MDMA for this project. And DEA, we do have, it should be soon now. I've been saying that for a year, though. I've learned a lot. We have our state narcotics license. We do have the Schedule I license from the Commonwealth of Massachusetts. And DEA does say, they even don't know. It could be any day, and they're checking on it, and they're certain that it should happen. And I'm trusting the people that have been interacting with us that we've satisfied their demands. So sometime in 2006, we should be starting the study at Harvard. No. The study that I'll be starting is with 12 individuals dying of cancer who are asking for help because they have anxiety and it's not being treated by standard medications, and they have limited time. And they'll be given, all of them will get MDMA. Some will get an ultra-low dose of 25 milligrams. But at least I can say to everybody that they will get MDMA when they participate in my study. And the other 8 will get a therapeutic dose, we hope, of 125 milligrams of MDMA split across 2 different times. And then the second time, starting off with 125 milligrams, and then 2.5 hours later getting half of that. And we'll be doing daily measures for pain and anxiety. That's the sort of work I want to get to. We've been looking hard at how hallucinogens may or may not cause harm. And now we feel ready to try to start looking at how they may be therapeutic. And I think the most exciting thing will be hearing, of course, that we might be able to do something with LSD and with psilocybin for cluster headache. But that is really dependent on how well things go in this particular study, too. So if you want to have research start again, it's about to. And I think that's a good thing, and that's now. Thanks.
I'm Valerie Mojeiko. I'm here to talk about MAPS research with Ibogaine in the treatment of addiction, and a study we're doing with patients who are treated at the Ibogaine Therapy House in Vancouver, an outcome study with their patients. A little background on Ibogaine first. It's from a West African shrub, Tabernanthe iboga. It's the ground-up root bark. Originally used by the Bwiti tribes as rites of passage. It's a picture of a shaman and his wife. Trying to go fast here to make up for that. Used in rite of passage rituals. Here's some pictures. And until it was brought to our culture by Howard Lotsof. He serendipitously discovered its effects, its ability to reduce or withdraw the symptoms from opiate withdrawal. So where Ibogaine fits in with other psychedelic treatments and addiction, there's been a lot of different research with this, with LSD. Alcoholics Anonymous, Bill Wilson used LSD in the treatment of his own alcoholism. And in the 70s, Stan Groff, Bill Richards, Walter Pankey, and others published research using LSD to treat alcoholics and heroin addicts, and had promising results. But what they learned from that is that multiple sessions might be more effective than single-dose sessions. And in this outcome study, we'll be looking at that somewhat too, not in complete depth, but looking at that as a variable. So if you're not familiar with Ibogaine, it's a psychedelic. It produces a dreamlike state, somewhat unlike other psychedelics. It's kind of, you need to concentrate a little bit to feel it. It's very long-lasting. It can last up to a week in some cases, but usually just 24 hours. And it's not very recreational. It's unpleasant for many people. And when addicts are using it for addiction, the trip may be related to the addiction. They may see things leading up to what caused the addiction and help them think about how it happened. And most importantly for us, for this study, is that Ibogaine greatly reduces the physical and psychological withdrawal symptoms from heroin, methadone, and other drugs. So a little background on the Iboga Therapy House, where our subjects will be coming from. It's located in Vancouver, BC. And MAPS awarded a $5,000 grant to set up this first Ibogaine detox facility in North America so that we can conduct research with their patients after they've been treated. And the Iboga Therapy House will provide, it previously provided treatments for free with money from Mark Emery, but in the future will just charge a modest fee for the treatments. If you're an artist and you see your artwork in here, I hope you don't mind me using it. So the way that the treatment works at the Iboga Therapy House, before they come in, they're screened. There's an application, a physical exam, and drug test. They come into the facility and are supervised for 12 to 24 hours to make sure that there's time for the drugs to get out of their system, because if Ibogaine is taken with heroin or speed or other drugs in the system, it can make those effects much stronger and cause a bad reaction. And then after the supervision period, they're given the Ibogaine. They lay down in a room with the facilitators there, and that will last for 1 to 2 days, depending. They haven't had anyone last more than that, but it's possible that it could. And then 2 or 3 more days, they stay there for integration and therapy, and they talk to the therapist. They do different healing things with them, yoga and massage and stuff like that. And after the week is over, they leave. And then where MAPS comes in is they do follow-up then for 1 year, monthly phone calls, and that's the data that we're going to use for the study. The main questions that we want to ask with the study are, how well does Ibogaine work? How safe is it? What percentage of people benefit and to what degree? How can these treatments be improved? And should more formal studies be conducted, such as clinical trials like we're trying to do with MDMA in the States? And the role of MAPS is to evaluate their program, provide feedback for them and for other clinics to develop a treatment manual for doing the Ibogaine treatments the most effectively and safely, and then collecting data for research and publication. I have a little bit of preliminary data from when the clinic was previously operating, and it was really promising, which is why we're going to go ahead with the study. There were 20 people, 6 out of 7 who were treated for cocaine or crack were abstinent, an average of 6 months after the treatment. 3 out of 8 who were treated for opiates were abstinent, an average of 6 months after. And 4 out of 5 who were treated for other substances, such as alcohol, crystal meth, or a combination of substances, were abstinent. And those numbers were 43, 80, 20-something percent, or the normal rate of abstinence is 20% for most treatment programs. So those are all really impressive for Ibogaine. A little bit of background about the study. We're just seeking to obtain basic preliminary data. It's not a controlled study, but it is representative since we're going to study 20 people who were treated in a row. We're going to do a 1-year series of questionnaires and interviews from 20 subjects and verify these interviews with contacts with a significant other, which can be a friend or family member or therapist. And we're keeping a harm reduction model in mind and measuring abstinence as well as non-abstinence outcomes. The measures we're using are the Addiction Severity Index as our primary variable. It's a long 1 to 2 hour interview that takes a portrait of everything in the subject's life on 7 different areas. So it's not just asking how they're using, but if they're using or not, but how they're doing in their job, their social life, their family life, those kind of things. The peak experience profile, which I'll explain better in a minute, That's going to measure the psychedelic experience itself. Beck depression and anxiety to track that, and subjective and objective opiate withdrawal scales to measure whether the Ibogaine works in the short term to actually get rid of their addiction. And pain and craving skills. So the addiction severity index, these are the 7 areas that I was talking about: the medical status, employment and support status, drug use, alcohol use, legal status, family and social status, and psychiatric status. So it's very harm reduction compatible, and it's been used extensively on a lot of studies. The peak experience profile is our really interesting test that we do to measure the highs and lows of the psychedelic experience. There's a few sample questions here. So it's scored like 0 to 4. 0 is not at all, and 4 is more than I imagine to be humanly possible. Experience of insight that all is one. Experience of explosive ecstasy. Experience of unbearable tortures that will never end. And sense that the experience cannot be described adequately in words. With open eyes seeing objects around you turned into great works of art. And this is our schedule. Just you can see it's months on the top. The addiction severity index the whole way through, as well as the other ones. The peak experience profile is just done every time that they do the Ibogaine. Some of our challenges are that we are not doing drug testing. That was under debate. I think that we're still not doing drug testing. And that it's hard to remain in contact with somebody for a year. And we're addressing those challenges by adding the check-in with a significant other, getting 3 names that we can call to check up on the person if we can't get in contact with them, or if we can, to verify the information, and gift certificates given periodically to encourage them to stay in the study. So far, we've finished the protocol design and training phase and submitted it to the IRB. And we've obtained partial funding from private donors. And I believe the Iboga Therapy House is still seeking additional funding for operating costs. Our goals for the study, once again, are obtain basic information about outcomes in underground Ibogaine clinics, provide feedback to improve services and help with funding from the Canadian government, and increase the safety. And ideally, if the data is good, lead it to placebo-controlled double-blind studies and clinical trials. And most importantly, to provide Ibogaine to drug addicts in a safe, supportive, and humane setting. That's all. Thank you. We'll do questions later.
Can you hear me?
Yeah.
I would like to ask you how many female subjects you tested. There is information by Naranjo that Ibogaine is dangerous more for female as for men. What do you think about it? Is here somebody who has experiences with Ibogaine and can confirm these preliminary statements from Naranjo?
Okay. He asked whether what we think about some information that says that females, it may be more dangerous for them to take Ibogaine. We don't know exactly who the subjects are going to be yet because they haven't been treated yet, but that's something to take into consideration. I know the one person that I know of that their experience lasted for a whole week was a female, or actually the 2 people that I've heard of. And I know some treatment providers take that into consideration, so that's definitely something to look out for. I think, okay. Does anyone have another question?
Which doses do you prescribe?
We're not administering the Ibogaine. The dose is, I believe, in the 15 to 20 milligrams per kilogram range.
Do you have
Who do we have working?
Is it MAPS in Vancouver?
No, the clinic where we're conducting the study, we're not administering Ibogaine. This clinic is independently operating. It's Sandra Carpeta's, the Iboga Therapy House. Oh, I don't know the answer to that, but she had a question first.
I have a nephew in Canada who's been diagnosed schizophrenic. They say it's because he took some drugs years ago, but he doesn't talk about it. Would it make sense to give him your address? Do you think to take this Iboga would help him?
I don't know about that, but I can talk to you later. Though the question was that she has a family member who is schizophrenic after taking different drugs, and would Ibogaine help him? I don't believe that they treat people with Ibogaine who have a history of schizophrenia, but I'm not really qualified to answer that. Okay, I think Michael Mithoefer is going to be next.
Thank you. Thank you. Can you hear me now? This is going to be a really brief overview of our study, because I only have 10 minutes, but I want to tell you a little bit about what we're doing. This is a phase 2 clinical trial of the safety and efficacy of MDMA-assisted psychotherapy for people with chronic post-traumatic stress disorder. And my wife and I are co-therapists for the study. We're doing it in South Carolina in the U.S., and it's sponsored by MAPS. Just to give you a sense of where we are, or what it took to get approval, the timeline for the approval is that we originally got our FDA approval in November of 2001, and then we got institutional review board approval, which is equivalent to the ethics committee here in Switzerland. That was in 2003, the fall, and then we finally got our DEA. I got my DEA license to use the MDMA in February of 2004, so that was the slowest part. And then our first subject was enrolled in March of 2004, so not quite 2 years ago. So I'll just tell you briefly a little bit about the study design, the therapeutic approach, and something about our preliminary results. It's a double-blind, placebo-controlled protocol for PTSD that's either crime or war-related. So far, we have not recruited any veterans, any people with war-related PTSD. So far, it's all been crime-related, such as rape, physical assault, childhood sexual or physical abuse. Our design is for 20 subjects, and they all have to have treatment-resistant PTSD. They have to have had at least 6 months of psychotherapy and at least one trial of an SSRI, a serotonin reuptake inhibitor. Most subjects have had a lot more than that. Most have had years of therapy and multiple drug trials before entering the study. And there are 2 stages. In the first stage, it's a double-blind protocol in which 60% of people receive MDMA on 2 occasions, 125 milligrams, and 40% receive placebo on 2 occasions. In stage 2, it's an open-label stage for the people who got placebo during the first stage. At the 3-month point, when we do the final outcome measures, if they want to, they can continue on to stage 2, in which they have 2 MDMA sessions. The MDMA or placebo are administered during 8-hour sessions when my wife and I are with them the entire time. And then there are 11 additional non-drug therapy sessions of 90 minutes in stage 1, and in stage 2, then there are 9 additional non-drug therapy sessions. Those are for preparation and integration. The screening and outcome measures, which I'll talk a little bit about in a minute, are done by a psychologist who is independent of the treatment phase, is not involved in the treatment, so we don't do that ourselves. Our therapeutic approach, just briefly, is based on LSD psychotherapy model that Stan Grof published in LSD Psychotherapy. That was actually our primary reference to the FDA about our method was Stan's LSD psychotherapy, and my wife and I both trained with Stan in holotropic breath work, and that's the method we use. Others, of course, have written about it with MDMA, including Ralph Metzner and others. It's a very non-directive technique of supporting the person's emerging experience, and we prepare them and encourage them to stay with any difficult experiences that come up, the idea being to move through the experience rather than move away from it. People start out reclining with headphones, music, and eye shades, and then what develops is a rhythm of alternating periods, some periods of focusing inward with the eye shades and headphones on, other periods of talking to us, and we have no schedule for that. We let it evolve according to what's happening for the person and try to guide them a little bit maybe in having a balance between those two experiences. As I said, there's an emphasis on staying with the experience rather than moving away or suppressing experience. We pay a lot of attention to set and setting, to meeting with people beforehand and preparing them for the experience and for this attitude of opening to whatever comes up. And then there's a lot of attention. We also involve their partner if they want us to, in educating the partner about what we're going to be doing so they have good support. And then there's a lot of emphasis on follow-up sessions and integration. After the 8-hour session, they spend the night in our offices with a psychiatric nurse there, mainly to give them dinner and to give them a quiet time to not have to go into the outside world. Then we meet with them again the next morning before they go home. Then daily phone contact for a week, and then approximately weekly therapy for a month after that, after each of the 2 sessions. Where we are now is that 9 subjects have completed stage 1, and then 2 of the placebo subjects have gone on to complete stage 2, the open label stage. We have 2 additional subjects who are in the study and will finish in about 2 weeks, and 1 subject who dropped out for reasons not related to the MDMA. I want to emphasize that this is preliminary data. We're not drawing any conclusions from this. It's too early to say. We're not doing statistical analysis on it, so it should be taken just as that, but it gives you a flavor of what kinds of things we're seeing at this point. We don't know what we're going to see by the end. The first little bit of data I want to show you is the neuropsychological measures. It's not part of our primary outcome data, but we are doing 3 neuropsychological measures before and at 3 months to just track whether there's any evidence of any neuropsychological problem from giving these 2 doses of MDMA. And I'm just going to show you the first one, which is really the most comprehensive of the 3, the repeatable battery for assessment of neuropsychological status. And these slides, just to orient you, the 6 pairs of columns on the left are the MDMA subjects, and the 3 on the right are the placebo subjects. Then the dark bar on the left is the baseline before they received MDMA, and the lighter bar on the right is the result at 3 months after they received MDMA twice or placebo twice. And the higher the score, the better the functioning. So as you can see, there's definitely no trend of any neuropsychological deterioration. It's at least as good afterwards, and possibly a trend toward improvement, maybe from less anxiety. So that's reassuring. And the other 2 neuropsychological measures have similar results. Then the actual outcome measures for the PTSD symptoms, there are 3 of these: the clinician-administered PTSD scale, which is the primary measure, and we chose that because it's the measure that was used in the Paxil and Zoloft, the paroxetine and sertraline trials. Those are the only 2 medicines now approved by the FDA for PTSD. And so we wanted to use the same measure of PTSD symptoms that they use. Then we also use these less specific measures, the impact of events scale and the symptom checklist 90. Here are the results. This is stage 1, the double-blind controlled stage, placebo-controlled. And just as in the other slide, the 3 sets of bars on the left are the MDMA subjects. The 6 on the left, and the 3 on the right are the placebo subjects. And then they go in order. The first bar is the baseline, and the higher the bar, the more symptoms they're having. The first bar is the baseline. The second bar is 4 days after the first MDMA session. The next bar is 4 days after the second MDMA session. And the last bar is at 3 months, the final outcome measures. This person only has 3 bars because the score at 3 months was 0. So again, this is preliminary data. We don't want to assume that it's going to hold. But as you can see, in 5 of the 6 placebo subjects, there's very dramatic decrease in PTSD symptoms, a lot of it occurring right within 4 days, and then in 4 of the subjects even lower at 3 months. This subject is interesting, did not have a strong response, had an increase in symptoms 4 days after the first session, and we tell people that their symptoms may get worse before they get better in this model of moving through the difficult experiences. But things get stirred up, then she had some improvement, and then finally it was back up not too far from where it started. So that raises the question, would it be useful to study more, have more sessions? But at this point, we're restricted to having 2 sessions. You can see that the 2 of the placebo subjects had either slight worsening or basically no improvement, and 1 was a pretty dramatic placebo responder. So I guess that demonstrates that we take seriously that we work with people, whether they get MDMA or placebo. We try to do our best to have meaningful therapy with them in either case, and this person had a strong response to that amount of concentrated psychotherapy, apparently. And this is the impact of events scale. We don't need to belabor this, but you can see it's basically the same pattern. 5 fairly dramatic responses. 1 who, MDMA subject who had much less response. And then in the 3 placebo subjects, again, this person the placebo responder had a dramatic response on that scale too, a little bit of response in this 3rd placebo person perhaps. And then the symptom checklist 90 just shows the same pattern. It's just everything was a bit less dramatic in these with this particular test, but you can see these 2 placebo subjects did not have a response. This one had some. And then the last thing I'm going to show you is the stage 2 data for the 2 people that had 2 MDMA sessions, the full 11 non-drug therapy sessions, went to the 3-month period and finished stage 1, and then went on to the open label stage in which they had 2 MDMA sessions and 9 non-drug therapy sessions. And so we repeated, with these people, we repeated the baseline measures at the end after they'd had 2 MDMA sessions. So the first light-colored bar, this is the CAPS. These 2 are the SCL90. These 2 are the impact of event scale. The light-colored bar was after all the placebo sessions and before the MDMA. The dark-colored bar is after the 3 months after the beginning of stage 2, after the MDMA sessions. So again, you can see these people these are the 2 that did not respond on the previous slides. The placebo responder hasn't chosen to go on to stage 2, which is not so surprising. But these 2 who did not respond in stage 1 appear to have quite a dramatic response, especially on the primary outcome measure when they went on to have MDMA. So that's a quick snapshot of what we're doing. We hope we'll continue to recruit and finish the study within the next year. Thank you. Are there any questions? We have been to Israel twice to meet with them, and we've spoken to we've presented information about our study, there a couple times, and we've collaborated with them. MAPS is sponsoring their study too, so we've worked quite closely with them, actually. Yeah. I'm sorry, I forgot to repeat the question. The question was, are we collaborating with the people in Israel who are doing the PTSD study there?
They need to come to Michael and Annie for training. Before we start that study, the Israeli therapy team comes to observe Michael and Annie run a session. So we're trying to standardize the drug and then standardize the psychotherapy component as well. And that's for the whole treatment manual process.
Yeah.
Could you speculate on what made these changes exactly in the MDMA? What do you think?
Well, what I think is that, the question is, can I speculate on what made these changes with the MDMA? Well, I think it's pretty much in line with our hypothesis, which was that, part of PTSD involves high levels of fear and defensiveness and difficulty with trust. And some of the characteristics of MDMA are that it tends to decrease fear and defensiveness, increase empathy and trust. So I think that's the kind of thing that's happening. It seems to allow people to revisit their trauma in a deeper way than they ever have before, and still be in connection with their emotions, but have a sense of not being overwhelmed by their fear, a sense that it's actually okay and safe to revisit it and see it more clearly. That's part of it, so they're able to face and process the painful experience. The other part is they tend to have a have it sink in deeply that they've survived the trauma. People who say logically, my life is actually is actually good. My husband is supportive. My family is fine. I shouldn't feel this bad. I made it through that. But that doesn't sink in on an emotional level. And what we're seeing is, with the help of the MDMA, they're able to actually have that sink in and really feel, yes, I did survive. Things are okay. Yeah.
There was that subject that responded fairly well to the placebo. Why did she or he not enter the open label stage?
The question is, why did the subject that responded well to placebo not enter the open label stage? I don't know. We have offered it to her, and she said she wants to do it, but had scheduling problems and would get back to us, and it's been a year. So there's not much motivation, I guess. It's pretty interesting that she hasn't. Yeah.
To what extent are the people that are doing the measuring aware of the study? And what I'm getting at is the objectivity, I guess, since there's a subjective measure.
Yeah, it's a question about to what extent are the people doing the measuring aware of the study. Well, it's a neuropsychologist who is very aware of the study design, but he doesn't see any of the records from the sessions, and we don't tell him about what happened during the sessions. So, of course, anything he learns directly from the subject, because obviously the blind is a problem with this, an inherent problem in this. It's definitely a limitation of the double-blind design that about an hour into the first session we know what the person got, and they tend to know, although one time we weren't sure the first time, and the person who responded thought maybe she got an MDMA. But so the blind is much better for the psychologist. And he, interestingly, came into this with no background in psychedelic research and no particular propensity for it. But when I presented the idea to him, he thought it sounded kind of interesting. And so he certainly was effectively blinded at first. More and more, he gets a feel for the way people look afterwards. So, yeah.
Is there material from the placebo?
It's just lactose. It's an inactive. The question was about the placebo. It's an inactive placebo.
In the Swiss and Israeli studies, we're going to use low-dose MDMA as like an active placebo, but not enough, like 25 milligrams. And that's the way the FDA wants the phase 3 studies as dose-response studies. So we just didn't want, well, what happened with Charlie's MDMA study is that one person had a panic reaction in Charlie's MDMA study, the dose-response study, and we were all really worried about that, and it turned out that was a placebo person. Really lucky. But we didn't want to have an active placebo in this initial study because if somebody did have a problem in the placebo dose, it would still be blamed on the MDMA. So methodologically, it's not as good to have an inactive placebo, but for this one, we felt overall it was the best way to go. And now we're moving differently for the Swiss and Israeli studies.
Any other questions? Thank you.
My name is Charlie Grob. I'm a psychiatrist from Harbor UCLA Medical Center in Los Angeles. Happy to speak with you today about some of the work we're doing. I have some PowerPoint slides, but given the limited time for right here, I'm going to save those for tomorrow on a couple panels, and I think I have more time then. But, basically, I've been interested in this area for a long time. Some 35 years ago, I made the decision to go to medical school pretty much on wanting to study psychedelics. I had read the literature voluminously. I had heard Stan Grof speak. I was just really impressed with the extraordinary power that these compounds had to facilitate healing, to be used in a therapeutic context. The work coming out of the 1950s and 1960s were really inspiring. And I remember walking out of Stan Grof's lecture in New York City in the fall of 1972, just feeling this is what I want to do. So, I went, did all my pre-med, went to medical school, expecting that by the time I got out, there'd be somebody's thriving psychedelic research project to become part of. Well, by the time I got out of school in the late 70s, there was nothing going on. So I just kind of kept my interest to myself because I found in large part the academic medical environment was not hospitable to this topic. And I kind of, went to the library every month and the new Index Medicus coming in to see what was new in lysergic acid ethylamide, and for the most part, very, very little. So there was a long drought. There was a long period of just, extraordinary inactivity in this field after the very exciting and promising studies of the 50s and the 60s. In the early 90s, I became interested in MDMA, and along with some colleagues, including my friend Gary Bravo, we started to critique some of the neurotoxicity research, particularly coming out of Johns Hopkins by George Riccardi. We felt that work was seriously flawed, and started to publish some of our thoughts. And it was through our publications that Rick heard about us, and he contacted us and encouraged us to apply for permission to work, doing a clinical research project with MDMA. And initially, we went in to do a treatment study for end-stage cancer patients. We felt if this neurotoxicity issue is on the minds of the regulators, at least they wouldn't be that concerned about people who had very limited life expectancy. However, they were not ready for any treatment application, but they did encourage us to file a protocol to do a phase 1 safety study in normal volunteers, which we did and which we completed in the early 90s. We then tried to extend it to, again, a treatment application. However, the MDMA neurotoxicity issue had become so sensationalized, and it really put a lid on moving any further. Let me mention that I've also done ayahuasca research, primarily in the Brazilian Amazon, with my very good colleagues Dennis McKenna and Jace Calloway. And in the early 90s, I was down there with Dennis and Jace studying members of an ayahuasca church that had permission from the government since the late 80s in Brazil to use ayahuasca for ceremonial purpose. And we worked them up along a number of different parameters, and were really impressed with the functional status of these people, many of whom prior to their entry into the church had been seriously dysfunctional with alcoholism, drug addiction, violent discontrol, all sorts of psychopathologies that were destroying these people's lives, destroying their families. They joined the ayahuasca church and had these remarkable transformations. We did a tightly controlled study looking at long-term users of ayahuasca. We had a normal we had normal controls that had never used ayahuasca. We contrasted the two on neuropsychological parameters, personality parameters, psychiatric histories, and found our ayahuasca-using subjects were scoring better on many of these parameters than the non-ayahuasca-using controls. Jace Calloway took a lot of bloods back with him to his lab in Finland at the University of Kuopio and did analyses for serotonin receptor densities and found surprising degree of upregulation, increased density of serotonin receptors. We found this may be perhaps a biological mechanism for the observed positive mood regulation effects, positive antidepressant effects that that ayahuasca has. And in fact, we could even speculate that perhaps there might be a mechanism for treatment of depression very different from the standard SSRI approach, which causes downregulation, increased, rather decreased density of serotonin receptors. Also in 2001, with my colleague Marlene de Rios, again with more Brazilian collaborators, we did a study with adolescents whose families belonged to the UDV church and who had been participating in sessions since they hit puberty. In Brazil, the women take ayahuasca during pregnancy. They take it during labor and delivery. Babies are baptized. Kids have an option once they become teenagers to participate with their parents. The judiciary was having some concerns. They wanted a study. So we did, again, another controlled study looking at ayahuasca-exposed youth versus non-exposed. And again, we found high levels of function. These kids had done very well in spite of, or perhaps because of, their participation in these ceremonies. So again, I'm very impressed with the potential of ayahuasca to facilitate transformative experience, and very much looking forward to the day that we could do that kind of work in the United States. It's been impossible to date, in part because we're looking at plant compounds, we're looking at a combination of plant compounds, and we're looking at a very potent hallucinogen. But at least we were able to do that work in Brazil. Let me mention, because I only have a few minutes here, the study we're doing currently, and this is a study with psilocybin, and it's and this protocol was developed and funded, developed in collaboration with the Hefter Research Institute and funded by Hefter. I'm on the board of Hefter. And essentially, when it became clear that the FDA was not going to give us permission to work with MDMA in cancer patients, because since the early 70s, I've been so impressed with Grof's work, Eric Cass' work, Bill Richards, Al Kurland, Walter Pankey, who've done such extraordinary work with people with advanced stage cancer. This was a study I wanted to do. The bubble had not yet burst on the neurotoxicity myth, and we found we could not progress any further. So we rewrote the protocol for psilocybin, which has some advantages beyond the political. We also felt it might be physiologically better tolerated by our subjects, all of whom are seriously medically ill. Many of them have serious organ system failures. We felt psilocybin was a gentler compound, particularly for cardiovascular effects. We would not be that concerned about hypertensive reactions, which could be more of an issue with MDMA. It took us years, and one issue about working through the regulatory system and getting approvals, it's possible if you have the credentials, you have the right setting to do it in, but you've got to be incredibly patient and persistent and very stubborn in moving forward with this. And we finally did get all necessary approvals. And a year and a half ago, we began our study where we're allowed to give psilocybin to people with stage 4 metastatic cancer, and we're treating the anxiety primarily, this profound degree of existential anxiety that is almost universal in people with these kinds of predicaments. We're also looking at effects on mood regulation and also pain. Keep in mind that Eric Cass, in his land-breaking work in the early 60s, looking at LSD treatment of terminal cancer patients, found a surprising degree of attenuation of pain, lessening of pain. And this is such important work to follow up on, and it really is a travesty. It's really a crime that it's taken decades to be able to pick up where Stan Grof was forced to put his study down because he was no longer permitted to continue by the early 70s. So it took from the early 70s to just a few years ago before anything was possible in this area. But So we've got a protocol. We're allowed to give a moderate dose, not as high a dose as I would like. The dose is 0.2 milligram per kilogram, but we're finding still, a substantial effect on our subjects. It's a double-blind, placebo-control protocol. Everybody is their own control. They come in on 2 occasions to our clinical research unit at Harbor UCLA. On one occasion, they get the active medicine. The other occasion, they get the placebo. The order is randomized. It's double-blind. So, technically, neither we nor the patient knows what they're getting. But though I tell you, by the end of the first hour on the first session, it's clear what they've gotten. And nobody is fooled, but by a long shot. We've studied 5 people to date, interestingly, all women between the ages of 48 and 60, all with stage 4 metastatic cancer. They're still all alive. They've had impressive degrees of amelioration of anxiety, improvement, mood regulation, overall function is improved. We're very, very encouraged. We've had some recruiting problems. This is a tough study to recruit for. We've had people approach us who seemed very interested, very good candidates, and then their medical status deteriorated, and they passed on before we could get them actually enrolled in a study. There have been some other logistical obstacles, but I think we're finally getting over them and are really, I think, ready to polish off the next. We're approved to study 7 more. We've got 1 more in the pipeline, then 6 to go. And after that, we're going to go back to the FDA and request approval for an expanded study where I think we would like to get all of our subjects reported very positive experiences with psilocybin. Their only complaint, and it was consistent with each and every one, was they felt the placebo session was a waste of time. So, which is not surprising. Although I tell you, I thought there was some value to it. I mean, we sit with them for 6 hours. Myself, my co-investigator, my research nurse, and even the placebo session. We do a lot of processing with them. We do. It's 6 hours of intensive psychotherapy. We get to know them a lot better. They get to know us a lot better. And there is a value. But I think for the kind of research we want to do, it'd be optimal to get approval for perhaps 2 or 3 sessions spaced a month apart. And we think we would be able to, augment these positive changes that we're observing. So I feel, it's taken a long time to where we're going. Sometimes we get criticized, we're going too slow, but given how things fell apart years ago, I think there's some wisdom to being cautious and methodical about it, but we have made some progress, and I tell you, this is an extraordinary area. My views haven't changed at all from how I saw things 35 years ago insofar as an extraordinary potential psychedelics have to heal, particularly individuals who are refractory or non-responsive to conventional treatment. And another patient group that is just begging to be studied again because they were some of the most impressive subjects to respond in the 50s and 60s, and they still represent some of the most challenging patient groups are chronic alcoholics and drug addicts. If you look at the progress of medicine over the last 50 years, I challenge you to find any area in medicine where there has been such minimal advance, such minimal progress in treatment as the treatment of alcoholism and drug addiction. I mean, today, your physician will tell an alcoholic pretty much the same as what they said 50 years ago, which is find a 12-step group, and if it's a good fit, maybe it'll work. And if it's not a good fit, well, by and large, you're out of luck. Humphrey Osmond was one of the first to look at alcoholics, and what he found, I think, has really interesting implications. He found that those subjects who did the best were those who experienced not just beautiful aesthetic experience, not just powerful autobiographic experience, but these were the people who had powerful psychospiritual epiphanies, who had a mystico-mimetic experience. There was something intrinsic to that powerful spiritual emergent experience, a transpersonal level experience that seemed to be healing and seemed to protect these individuals from relapsing into alcoholism in the future. And remembering what William James once said, the founder of American psychology well over 100 years ago, talking about alcoholism, which he referred to by the quaint term of dipsomania. He said, the best treatment for dipsomania is religiomania. And sure, we could see that in all sorts of religions. Everyone has their, takes pride in their conversion stories. Nevertheless, there's something uncanny here that you've got a potential treatment model where you could reliably induce that level of experience, I think you've got an extraordinary treatment. I think it really could rewrite the book on how psychiatry, how medicine approaches addictive disorders, how it approaches alcoholism. I still have trouble getting my mind around the notion that they had such promising preliminary data, 4 decades ago, 5 decades ago, that nothing, and it wasn't allowed to continue. But I'm thinking now things are starting to open up. This conference is incredibly encouraging. Large numbers of people coming, with kind of like-minded, sharing a vision, and the impressive talks I'm hearing from colleagues from Europe, from the U.S. I think the time is ripe that we are going to be able to take this model and move forward with it, and we'll talk more about that later. Thanks a lot. I can't hear you. Yeah, any comments or questions? Yeah.
Do you have an explanation why psilocybin should weaken the anxiety of the people, these cancer patients?
Well, yeah, they all have. We haven't broken the. Yeah, why does psilocybin lessen anxiety of cancer patients? Great question. We haven't broken the blind on the instruments and the inventories we have them fill out, but our observations are all consistent. These people are much improved. It's almost as if they've had a release, a catharsis, a letting go of that existential angst that they felt gripped by. And although I wouldn't say any of them, I don't think we have a dose yet where we can push them into this mystical level experience. I think they're getting an approximation of that, a sense of the numinous, a sense of perhaps a level beyond this. And again, we could speculate. It's a great question. I don't have a definitive answer, but our observations so far are consistent, and they're consistent with what Stan Grof saw, what Bill Richards saw, what the other great investigators of the 50s and 60s saw, that there are significant lessenings of anxiety. Yes, Peter.
Does psilocybin have an impact on cancer pain? And if yes, only during the session, or is it long-lasting?
Well, Eric Cass was an internist at the University of Chicago in the early 60s. Repeat the question? So the question has to do with, the pain. How long does the effect on pain last? Just short-term during the session or extended afterwards? Eric Cass, who was a pain control expert, he didn't know anything about LSD. He had never heard about psychedelics. But here was a new compound, and on a hunch, he started administering it to his cancer patients without even explaining what it was, because he didn't even know what it was. And by today's standards, impossible, could never be done. But he observed that their pain lessened, not only during the if it's psilocybin, 4 to 6 hours. If it's LSD, 8 to 12 hours. He found that their experience of pain attenuated, lessened for days afterwards, for weeks afterward. They needed less narcotic medication to control their pain. He came up with something he called a theory of attenuated anticipation, that he felt a lot of these people were caught in a pain cycle, not only experiencing pain, but anticipating that this pain would continue and would not lessen and would always be with them. Suddenly they broke that cycle. They were able to step back, detach. And suddenly, experience of pain was much less. Need for narcotics, much less. Fascinating observation. Again, why colleagues of that era didn't, march on the regulatory agencies en masse and say we gotta work with these tools. It has to do with the cultural turmoil at that time. Nevertheless, these are extraordinary models, and I think a lot of suffering people could benefit enormously. Yeah.
change hearts and minds by publications in medical press and the popular press. And I thank yourself and Rick and Max for the support and encouragement I've had for that. But looking at the years, if not decades, of obstacles that you've been through to get where you are, where do I start? I'm trying to get some clinical
Well, you've already made a great start. I've seen your articles. They're excellent. I'd recommend Ben Sess's articles to others, excellent reviews of the field. You just have to, be persistent. You have to just kind of maintain that vision. Don't lose heart. And it's so important to meet with colleagues, people who share that vision. For me, I was in a desert from the 70s until the early 80s. When I left Johns Hopkins and moved to the University of California, I connected with Gary Bravo and Roger Walsh. From there, we met Ralph Metzner. These were psychiatrists and psychologists who shared the vision. Now, I guess in my case, I had to move to California. I don't necessarily think you have to do that. Hopefully, the globalization phenomena, California will come to Britain.
I'd love to see it in the UK because I think that the UK has a real strong history in the 1950s.
Yeah, Ronald Sanderson, an analyst, was one of the very first, psychiatrists to investigate LSD as a therapeutic adjunct going back to the early 1950s. He was a pioneer, and there really is a tremendous, there really needs to be further work done. A new generation needs to emerge in Britain, and look, the fact that you've stepped forward, that's one more than we would have identified a couple years ago. So you just hang in there and connect. Okay.
My name's Andrew Sewell. I'm double trained in both neurology and psychiatry. I joined Harvard Medical School slightly over a year ago, and I'm working on the LSD psilocybin cluster headache study. Now, I guess the first question is, what is a cluster headache? We all know what migraines are: unilateral throbbing headaches accompanied by nausea and vomiting. Feel better if you lie down in a dark room, go away when you fall asleep. Cluster headaches are really not like that at all. The quality of the pain is much different. Whereas migraines are a dull throb, cluster headache, it feels like a hot poker is being jammed slowly into your eyeball. Lasts about an hour and then it goes away. It's accompanied by a drooping eyelid and a dilated pupil. I mean, you can't fake having a cluster headache attack. All you have to do is look at the eyes, and the pupils are unequal size. There's no nausea. And what's more, rather than lying down making it feel better, that makes it feel worse. People with a cluster attack, they thrash around, they bang their heads against walls, they pace up and down, they hold their heads. And rather than sleep making it go away, sleep tends to bring it on. In fact, the first REM sleep of the night tends to be accompanied by a cluster attack. So cluster headache sufferers often develop a sleep phobia because they know that as soon as they fall asleep, they're going to be woken up with a hot steel poker through the eye 90 minutes later. And the other difference is it's much rarer than migraine. I would guess in an audience this size, there's probably about a 50% chance that somebody has cluster headache. In fact, let me ask, is there anyone here with two? Well, we've got two, actually. Three. You had it. Okay, well, there we have it. A cure. Okay, so essentially that was the rest of my talk. So any questions? No. The other thing I want to point out is that the people sitting next to these cluster headache sufferers, you couldn't tell they had it, right? I mean, it's a rare disease, it's not talked about much, but people are around and it doesn't necessarily show. Now, our story begins in Scotland with a Scotsman who had cluster headache from early childhood, hit his early 20s, discovered LSD, cannabis, cocaine, shrooms, whatever it was, he took it, went through a few years without cluster headaches, didn't really put two and two together. Then in his mid-20s, he cleaned himself up, settled down, got a job. Cluster headaches came back, but again, he didn't put two and two together. Until he was 30 years old, he was on a honeymoon with his wife, and they decided to take psilocybin together for old time's sake. And they did, and his cluster headaches went away. And this time he thought, wait a minute, what if? So he waited for the headaches to come back again, and then he took psilocybin, and once again, boom, gone. So he went to the internet. This was 1998, and he started to talk about it with people, and he was roundly ridiculed. Nobody wanted to hear that psilocybin, illegal, bad, brain damage, blah, blah, blah. But one by one, he managed to convince other cluster headache patients to try it. And it worked, and it worked, and it worked, and it worked, and it worked. And by the year 2001, the 38th patient took it. His name was Bob Wald. He had a particularly severe case of cluster headache. It was refractory to all medications and all treatments. And what's more, he didn't have just one bout a year. He had it continuously. He couldn't work. He couldn't have a family. And he was actually contemplating brain surgery because the treatment for the most extreme form of cluster headache is you drill a hole in the head and put an electrode down into the hypothalamus and just have a little trickle current. And it works 60 to 70% of the time, and the chance of dying from this is less than 10%. So if you actually consider the odds, more likely than not you'll get better and probably won't die. So this guy is LSD cures cluster headache, and he's a middle-aged, God-fearing Midwesterner who knows full well that LSD causes permanent brain damage and doesn't want to have anything to do with it. But it also occurs to him that an electrode in the brain also causes permanent brain damage, so he thinks that maybe he'll just give LSD a try. And lo and behold, it works. His cluster headaches go away, and he's furious that his neurologists have not told him this. Why are they going to do brain surgery on him when a perfectly effective treatment is available? And the reason is we didn't know about it. That's why. And the reason we don't know about it is not in the scientific literature. How do we ever find out? I mean, I've scoured literature going back 2,000, all the way back to Egyptian scrolls to find any evidence of this, and it's not written about anywhere. So he forms an internet group called the Clusterbusters, and you can find them, www.clusterbusters.org, hallucinogenic treatment of cluster headaches. It's all there. Dedicated to not only spreading word of this treatment, but also getting the medical profession to pay attention and run proper scientific studies. So he approached Harvard in the summer of 2004, or he actually approached Rick Doblin, who approached Harvard, because he knew I was a neurologist who was interested in cluster headaches and also psychedelics, and asked if I would take up the charge. So my first step was to write a case series. There's no point in trying to propose a trial to answer a question that hasn't even been posed yet. So I figured the Clusterbusters, they already had about 150 cases. Then I scoured the internet myself, going to other countries and posting in other non-hallucinogenic web pages, and found another 150 cases, and figured I could use those stories and extract some data from them. But the catch is, you can't really publish internet surveys because people are skeptical. Maybe it's a cluster headache patient, maybe it's a Joe Blow in Indianapolis who's having some fun with a Harvard doctor over the internet. So I insisted that people send me medical records to just verify what they were saying to me. And I thought that this was a kind of unlikely thing to happen. Who is going to send medical records documenting illegal activity to a faceless figure over the internet who could be a DEA agent? Who's to say, one way or the other, right? So the first record arrived, then the second, then the third, half a dozen, 2 dozen, 4 dozen. By the time the 50th set of medical records arrived, I figured I had enough. I mean, I could have kept going, but 100 or 200 wasn't going to be more convincing than 50. So I wrote the paper and I submitted it. It's been rejected twice. It's now sitting with a third scientific journal, and it's been 3 weeks now, and I haven't heard back. So I assume it's made the first cut. So now it's just a matter of time and continuing to submit to different places until finally it's published. Now, once that happens, the trouble with case series, it's basically just a collection of anecdotes. And in science, the plural of anecdote is not evidence. The obvious argument is, okay, so you found 50 cases of LSD curing cluster headache, but you could find, if you searched on the internet, you could find 50 cases of people abducted by aliens. It doesn't necessarily mean it's happened. But what it does is it raises the question. Here I found 50 claims, either it's true or it isn't, and the way to determine one way or the other is to do a controlled clinical trial. So while we've been waiting to see this case series published, we've also been working on a protocol for a design of a 2-armed trial of psilocybin versus LSD in the treatment of cluster headache, which we'll be submitting to the IRB as soon as John Halpern's study gets underway. Now, obviously the odds are, this is kind of a long shot. I mean, people have been trying to do LSD research for 40 years and no one's been successful so far. But I'm optimistic in this case for 2 reasons. The first is, there are about 300 people I'm in contact with out there with cluster headaches who have treated them successfully with psychedelics, who truly believe that psychedelics have saved their lives. And they're in all walks of life: bartenders, public relations firms, radio journalism, Washington lobbyists. And if this study is turned down, they will all be very annoyed. And I'm not sure what this group of people is capable of doing, if they're brought together, but I'm sure it's not nothing. And the other group that stands behind me is scientific psychedelic researchers. There are a lot of people who are. I'm just a young neurologist. I've never run a scientific trial before. I have very few publications, but there are a lot of people who are very interested in having me succeed. A lot of white-haired people who've run many psychedelic studies who have offered their services to help make sure I know what I'm doing. One guy who spent his whole life designing and running trials of headache medication, is volunteered to read over the protocol and make sure I'm not screwing up somewhere. So I'm not sure what the shape of what will be finally submitted to the IRB, but I can assure you it won't be sloppy. So there are many battles still to be fought, but I think what separates me from people like Rick Strassman, who finally got worn down by it and just quit after a while, is that I won't be fighting those battles alone. Any questions? What's the typical treatment of cluster headaches with psilocybin? Well, generally, first you have to detox off all your other medications, and that tends to be the hardest because there's a lot of things that seem to interfere with the psilocybin treatment. Opiates, for one thing, seem to block it, which I'm sure is why Cast had such erratic results back in the 50s with his cancer patients. He never separated who has on opiates and who wasn't, and things like Imitrex interfere with it as well. Oxygen doesn't. So after 5 days of no medications, then you take a dose of psilocybin, you wait 5 days, a dose of psilocybin, you wait another 5 days, and then you take a third dose. LSD tends to work better. Sometimes one dose is enough, sometimes they need a second, sometimes they don't. Now the interesting thing is the dose doesn't have to be hallucinogenic. This effect is entirely unrelated to the hallucinogenic properties of these drugs. People have had lasting headache relief from a quarter hit. And I think that's going to be another big selling point here as well. And I've looked at hundreds of cases, and I can't really determine if there's a dose-response relationship, though. I don't know if subhallucinogenic dose will be enough for everybody, or only for some people, or everybody will do better with a higher dose. I mean, that's why we have to do the scientific experiments. You, back? Other types of psychedelics? Yeah, it's very hard to know. I've got 2 cases with DMT, but you have to remember that cluster headache is a very rare disorder, and people who like psychedelics are pretty rare. You know, the people sitting in this room are not a common bunch. So I've really been unable to determine, or at least gather enough information to tell whether other psychedelics will be effective as well.
What is the length of the curative cycle? I suffer from cluster headaches, and I get them once every 3 years. Usually it's September, October. They last for 3 months.
Mm-hmm.
I can almost set my clock by when they're going to come.
This is very characteristic for cluster headache. He gets them every 3 years in September, and they last for 3 months, and then they go away for 3 years. Okay.
Does LSD prevent this particular cycle, or is it known to actually extend beyond the 3-year period?
Generally, people find that a year is probably the outside. If you wanted to prevent your cycle, you'd probably take it 3 months ahead of time.
A year is pretty amazing, actually.
It's actually impossible. It's completely impossible. You?
My question is, if the LSD is curing the cluster headache, is it a psychological cure, or is it a neurological cure? What is your theory of the action taking place there?
Well, my belief is the fact that it's a subhallucinogenic dose. And when I say subhallucinogenic, I'm talking maybe a little trippy feeling, colors brighter, but nothing more than that. Otherwise, I classify it as hallucinogenic. The fact that that works means that it's nothing to do with psychological. And also, this is a disorder that traditionally has a 0% placebo response. You can't fool someone into thinking that their headaches are being cured. So I do have a few theories about why it may be working. They're a bit complicated, though, and I probably need graphs. And also, they're all probably wrong as well. So I'd rather not stick my foot out. And now I've already answered one of your questions, so let me come back to you. Anyone else?
My question pointed in the same direction. This question was, did you hear anything about ketamine as an option for treatment of cluster headaches?
Have I heard ketamine as an option for cluster headaches? Well, ketamine's a dissociative anesthetic, so it would work sort of generally for any sort of pain. The only trouble with most pain medications is it takes time to get in your system. I suppose if you injected it, it would take away the pain of an acute headache, but it wouldn't necessarily terminate a cluster period or prevent other headaches from coming on any more than Imitrex would, which is another injectable treatment.
I heard of somebody at the Exatonspital here in Mithoefer in the Swiss, and that he is applying novel ketamine for the treatment of cluster headaches.
Oh, he is? I hadn't heard about this, but I'd certainly be interested to know about it. My prediction is it doesn't have the same effect as LSD, though. It's a totally different... like I said, I think it could cure a headache, and the same way it could cure, foot pain, but wouldn't keep it from coming back. Anyone else? How about you?
Do you intend to study D-LSD or D-iso-LSD or just all the various forms or possibly looking at the L?
Well, the forms that people have been taking to treat themselves have been the racemic form, so I don't see any reason to mess with that.
I was just curious because you said that some psychedelic doses were active. I was wondering if possibly non-psychoactive.
Well, this is going to be the selling point, too. I'm going to argue that this potentially opens up a research program where, bromo-LSD, for example, has no hallucinogenic effects. Quipazine is non-hallucinogenic analog of LSD. Maybe these have cluster-busting effects. I really don't know, and the only way we're going to know is to run the experiments. So, John.
Along those lines, are you aware of anyone who's looked at hydrogen?
No. No. I mean, it's possible, but none of my patients have taken it anyway. And anyone else? I know you had another question.
Well, it actually is a bit of a comment because I did discover stuff on the internet about psilocybin and cluster headaches several years ago. It's difficult for me to know whether I've actually experienced a cure because I've got a very good doctor, and the last time, I'm just lucky on this particular, the last time I actually had any cluster headaches, I had a very good doctor in hand. But I do think I've managed to prevent cycles.
You've prevented cycles with...
But with psilocybin mushrooms.
Okay.
Because there is a period at the beginning of the cycle, which I think is like they call a shadow or something, when you feel like in 2 or 3 weeks' time you're going to be in absolute agony. And I took mushrooms at that time, and the cycle didn't come on. I then went to my specialist with a whole load of stuff off the internet and told him what had happened, and said, look, because he told me point blank when he actually diagnosed me, I said, I know what you've got. Called cluster headache. There is no cure. I can't give you anything. It's going to be tough. You could have it for the rest of your life. And I went to him and I gave him all this evidence, and he just looked at me and said, I don't really think you want to go there.
That's the response of most neurologists. I'm not sure how many of you heard his story. He's saying that he gets a 2 to 3 week warning period before his cluster period begins. And this is very common. They can somehow tell in some indefinable way that it's about to start. And he took psilocybin during that period, and his cluster period didn't start. And we have no medication currently that does that. We have medications to treat cluster headache, verapamil and lithium. They all have kind of nasty side effects, usually need more than one. And what they do is they suppress the headaches during the period of the cluster period. But they don't terminate the period. If you stop taking them, the headaches come back, and the thing has to kind of run its course and burn itself out in the same way it would otherwise. Whereas psilocybin or LSD seems to just stop it. Nothing does that.
Can you mention any similarities between verapamil and lithium? Because they're quite different chemical agents.
Between verapamil and lithium, you mean? Well, verapamil is a calcium channel blocker, and lithium also has some electrolyte properties. I don't think anyone really knows why they work on cluster headaches, except there's some kind of rhythmic problem in the brain. It's a circadian rhythm disorder. And lithium, as you know, also works on bipolar disease, which is another problem of abnormal rhythms. Okay, I'm being edged. Bye-bye.
Okay. We're pretty much out of time. We'll have time. I'd just like to say that most of these studies would not be happening if it weren't for the generosity of John Gilmore, who's been our major supporter at MAPS. Renee Ruiz, who's also a donor, is here. And so these are studies that really require us from the psychedelic community to support. I'd also like to say that Alex Gray has made a commemorative portrait of Albert that Albert has signed. There are 50 copies of it. There's only about 5 left, and we're selling them through the MAPS table, and they go up as they get sold, as there's fewer and fewer left. So if you are interested, the money is restricted half to the Chapel of Sacred Mirrors, and then the other half to the cluster headache study, to the LSD and psilocybin research. I'd like to also really express my appreciation for John Halpern, that the work that he's doing at Harvard is central. If we wouldn't have his participation, we wouldn't have any of this happening at Harvard. And it's quite courageous in some ways what he's doing, because the DEA is not at all pleased or happy with this. We will have much more time for talking in the supplemental program from 4 o'clock to 7 o'clock tomorrow, Saturday, and the rest of us will stay around afterwards as well. So thank you very much for coming to the seminar.